Our there's the signal. So we are thrilled today to be here with the founding director of the Cardiovascular Division of the Centers for Disease Control, along with the current director of the Cardiovascular Division of the Centers for Disease Control, acting, although Janet Wright was the founding director of Million Hearts and has just been such a wonderful ally in this work. We have a plethora of riches of wonderful leadership from around the state. And I just want to say that everyone pitches in something for this work. This is what I call a we thing. It's all of us bringing our best, and it's together as a collaborative with intellectual contributions, volunteer contributions, and financial contributions that we have been able to propel this forward, really starting it just conceptually on my desk in 2006 and building it one person at a time, one person inviting the next person in. And one of the very earliest people to absolutely believe in this work was Bob Kaplan, who will be our facilitator for today. But I would be remiss if I didn't say we would not be here today if it were not for our original grant from the National Heart, Lung, and Blood Institute of the National Institutes of Health that Bob Kaplan was the principal investigator for. And also since that time, we have had support from, wonderful support from day one, from UC Berkeley School of Public Health, the Center for Health Outcomes Innovation Research, California Department of Public Health, Los Angeles Public Health, Blue Shield of California, the Stroke Awareness Foundation, various UCs, Stanford, USC, the American College of Cardiology, Johnson & Johnson, Genentech, two of our very early supporters from before we even started our first pilot, Novo Nordisk, the Santa Clara Health Trust, Boehringer Ingelheim, and Amarin and Amgen. Next slide, please. This is very much a joint effort. If you could please go to the next slide. I want to just emphasize that our work stays very, very focused on three biometrics that we know, if well managed, very significantly drive down heart attacks and strokes. So we know from our initial days, and we came up with these goals working with RAND back in 2007, along with the deans of the schools of public health of UCLA and UC Berkeley, that controlling the troika of blood pressure, LDL 100, blood sugar, HbA1c less than 8, that we can make a really, really big difference, and we need to stay focused on those, but we need to build from there. So next slide, please. So today, we are blessed with an amazing array of leadership from around the state, and Bob Kaplan will be introducing you to each of them. But I would just like to say we have leadership with us from our capital region, our San Diego region, our Los Angeles region, and our Bay Area Silicon Valley region. We are thrilled to be having an interactive discussion with the founding director of the Cardiovascular Division of CDC today, along with the wonderful Janet Wright, the founding director of Million Hearts, and so many of our leaders from around the state. So with that, I'm going to hand it over to Bob Kaplan to facilitate the day. And I'd like to say that Bob has had quite a storied career. When I first met him, he was the head of health services research at UCLA. And since that time, he's been the associate director of the National Institutes of Health, the chief science officer for the Agency for Healthcare Research and Quality. He's the chief science officer for Stanford Clinical Excellence Research Center, and he's our co-chair for the Silicon Valley Bay Area group that Blue Shield challenged us to start in 2018. It's been a lot of fun. And with that, I'm going to hand it over to Bob. Next slide, please. You are muted. There we go. So,
sorry about that. It's the age of Zoom. So thanks, Hattie. I'm just going to briefly mention some of the data that that RightCare has collected, and then it's my honor to introduce the speakers this morning. So one of the things that RightCare does is it assembles data on these metrics from the areas that we're associated with in California. And so what you see here are the performance levels for RightCare counties for blood pressure control at the top, and for blood pressure control with people with diabetes at the bottom. And I think the important message from this is there's a lot of variability in the performance of these health plans. And it appears that the bigger groups and the better organized groups perform a little bit better, or sometimes substantially better, than the groups that are smaller and perhaps less organized around these quality improvement metrics. By the way, these data are available on the RightCare website. Can we go on to the next slide? And I'm just going to skip over this. This is the same for glycosylated hemoglobin. RightCare uses this triangle, and so it focuses on proactive outreach, high blood pressure monitoring, and intensive ambulatory care. And it uses nationally endorsed protocols like from the American College of Cardiology or the American Diabetes Association, the NICE guidelines from the UK, and bundled medication therapy and so forth. It also has endorsed clinical pharmacists on the care team. I think Dr. Chen might talk about that a little bit later. So we can go on to the next slide. I think one of the most interesting evaluations from RightCare comes from San Diego. So San Diego is a very unique healthcare market where 4 major players have a substantial portion of all the people in managed care in that county. And so as part of our NHLBI grant, we had the opportunity to do some intensive meetings with people that were representatives of these 4 groups. And then we monitored age-adjusted hospitalizations per 10 or 100,000 people in the population before and after the implementation of this intervention. And as you can see, when this University of Best Practices was initiated, we had substantial declines for both men and women in San Diego County. Can we get the next slide? We often like to honor our colleague Warren Barnes, who was the former chief lawyer of the California Department of Managed Healthcare, where Hattie was working at the time I first met her. And he was the co-author of the Patient's Bill of Rights in California. Unfortunately, we lost Warren a little while back, but he was a great inspiration for what we're doing. Next slide.
I have to interrupt just to say that while Warren is not able to be with us, he is still advising me quietly in the background. He just is not well enough to be with us by Zoom.
So it's really my pleasure today to introduce my good old friend, Darwin Labarthe, who, as Hattie mentioned, was the founding director of the Division of Heart Diseases and Stroke. I think many of you know Darwin, but Darwin is a graduate of Princeton, and he got his MD degree at Columbia University, and then went on to get his MPH and PhD degrees from the School of Public Health at Berkeley. Actually, you know, Darwin has been all over the place, but he is a Californian and has come back home again, is now a resident of California. He did internal medicine training at Washington University in St. Louis, and then was in the general preventive medicine residency at Berkeley. Darwin has done all kinds of really interesting things in his career. So for quite some time, he was the convener of epidemiology at the University of Texas School of Public Health in Houston. And then in 2000, he joined the Centers for Disease Control and Prevention, where, as we've mentioned before, led this effort in cardiovascular prevention, cardiovascular disease prevention. Darwin has done a lot of other things in his career. We don't have time to get into all of them, But early on, he was a member of the faculty for the international seminar on the prevention of cardiovascular disease and stroke. And he went on to be the founder of the US seminar, which has been going on. I sort of lost that slide, but that's been going on, I think, 46 or so years, and Darwin has actually never missed one. It's been held at Lake Tahoe all of those years, with the exception of one where they went off to Colorado for one summer, but realized that you can't beat Lake Tahoe, and returned. But I think it's worth saying that that the seminar is kind of a rite of passage for cardiovascular epidemiologists. So just about everybody in the field has spent part of a summer with us at Lake Tahoe. I was really enthusiastic about getting Darwin to talk to us because so much of what we've dealt with in the Right Care Initiative has focused on a certain spectrum in the progression of cardiovascular disease and stroke. So we've dealt a lot with risk factors and the modification of risk factors. But when Darwin was at the CDC, he oversaw the development of the National Action Plan for the Prevention of Heart Disease and Stroke. And it's quite an intriguing document in that it looks at everything from dealing with rescue for people who are at the very end stages of cardiovascular disease, all the way through prevention of risk factors. And the part that I think Darwin will talk a little bit about today is at the very beginning end. That is preventing the risk factors from beginning in the first place. And Darwin does just an exceptional job of thinking about this long continuum from people with no risk factors at all the way through end-stage disease, and how we have to develop an action plan to deal with what our intervention steps are along this continuum. So, Darwin, thanks so much for taking the time to be with us today.
Bob, it's my immense pleasure. I thank you for the introduction, and it's good to see you. As Bob says, we have had the privilege of teaching together on the shores of Lake Tahoe for many years. And I welcome the invitation from you and from Hattie to participate with this group. As I said in our brief conversation prior to opening the meeting, I can't imagine a group with whom I would rather have this conversation. So I look forward to it very much. And I guess I need to share my screen. And here we are. So, and I should also just mention my special pleasure to see Janet. It's been episodic that we've got together over the years, and I've had the opportunity to watch with great privilege and pleasure at the immense progress she's made with the Million Hearts Initiative, and now in the chair of the Division for Heart Disease and Stroke Prevention at CDC. Good to see you, Janet. So I'd like to talk today about a perspective on the cardiovascular problem. And it has to do with the concept of cardiovascular health, the idea of a cardiovascular endgame, and a specific target and timeline we represent by 50 by 50 by 50. So a good place to start this conversation is with this figure from a paper in 2006 by Don Lloyd-Jones and others, based on the long-term follow-up experience in the Framingham Heart Study, beginning at age 50 and extending from death to as late as age 95. Represented by these curves are the adjusted cumulative incidence of major cardiovascular events over this period of follow-up from ages 50 to 90 plus, separately for men and for women. Now, I'm going to guess that what we see first and foremost is the top curve. The highest risk group experiencing for men 69%, women 50% of cardiovascular events over the follow-up period past age 80. But if we look more closely at the figure, at those with optimal risk factors, this is what we see. 5% events for men, 8% for women. They have virtually disappeared. What's the explanation? If Sherlock Holmes were asked, he'd say, my dear Watson, it's elementary. Absent the cause, the consequences can't occur. This wasn't an idea discovered by this analysis of Framingham's study. The earliest reference to it that I have found is one 50 years earlier from the Framingham Heart Study. And that report identified the lowest stratum of cardiovascular risk in terms of blood pressure, Framingham relative weight, and cholesterol. And the finding was, in the bottom line, the rate about 10 per 1,000 events in men was about 1/3 that of all women. This is among those who are at the lowest values, the lowest tertile of each of these three factors. That was about 11% of men who were 45 to 64, 45 to 62 at the beginning of follow-up. So the idea that low risk is important was noted in 1957, but largely overlooked in the long interval through the rest of the 1900s. A Stamler paper in '99 from the Chicago Heart Industry follow-ups made the point of low risk very clear, and the Framingham analysis in '06 that Don reported was a follow-up and a clearer graphic presentation of this idea. So we looked further into this notion of low risk and asked the question, what would this mean if the US population as a whole attained this happy status? And we teamed with the group at Liverpool, Capewell and others, to apply their CHD impact model to US population survey data from NHANES to say, if we know the situation of the risk factors in 2000 and the trends in the years immediately prior, what would we project to be the experience of coronary heart disease deaths in 2010, just 10 years later, under varying scenarios? Without going into detail about the others, I want to focus on the scenario of all Americans attaining low risk. And what do we see? Virtual disappearance of coronary heart disease deaths. 388,000 deaths would have been predicted for 2010. Only 372,000 occurred, 4% of those who would be expected. Absent the cause, the consequences don't occur. With this and ongoing studies through the up to 2010, the American Heart Association became very interested in this idea and convened the Statistics Committee and others, again under the leadership of Don Lloyd-Jones, to consider how to define cardiovascular health, measure it, and set targets that would be appropriate goals for AHA. And so this report published in 2010, defining and setting national goals, set the strategic impact goal for American Heart through 2020 and beyond. The definition being based on 7 factors: smoking, physical activity, diet, weight, glucose, cholesterol, and blood pressure. Separately for adults, 20 years of age, and children younger, stratified by poor and intermediate and ideal levels, which can be applied to each factor as well as an aggregate overall score. AHA's concept was that there was a potential to reduce the prevalence of poor cardiovascular health to improve to the extent of being intermediate, and correspondingly from intermediate to ideal. And with this definition and this concept in mind, AHA set its 2020 impact goal by 2020 to improve the cardiovascular health of all Americans by 20%, while reducing deaths from cardiovascular disease and stroke by 20%. A profound change in outlook, positive in orientation, beginning with health. It's worth noting the benefits of cardiovascular health in adulthood and adolescence that go beyond cardiovascular conditions. We see, for example, incident cancer, venous thromboembolism, end-stage renal disease, cognitive function, depression, quality of life, compression and morbidity, Medicare charges. Ideal cardiovascular health is good, not only for cardiovascular outcomes, but for health more generally in the population. So what do we know about cardiovascular health in the US population? If it's to be reduced or improved rather by 20% by 2020, where are we starting? Data from NHANES for each of the 7 metrics shows the distribution between green, ideal, yellow, intermediate, and red, poor cardiovascular health for each of the metrics. And so what we see is a lot of green, but a lot of yellow and a lot of red. And for diet, an abysmal distribution of 99.7% poor or intermediate, the ideal barely showing in the figure. Recalling that the definition stratifies by age, let's look at children as well at the same time. And what do we see? A lot more green, a lot less yellow and red, still dismal diet. What's the difference? It appears that we're losing cardiovascular health from childhood into adulthood. We asked the question, how does this happen? What's the pathway by which this change takes place? Pooling data from 4 cohort studies, Project Heartbeat, Bogalisa, Young Finns, and Cardia. We were able to construct statistically a synthetic cohort and assess the distinct trajectories of change in cardiovascular health metrics over this age span from 8 to 55 years. What we see, as expected perhaps, was at age 50, just as in the Framingham Heart Study, there is a distribution of levels of cardiovascular health, which has long-term consequences. What became clearer than before was that there is also a distribution of levels of cardiovascular health as early as age 8. So this raises an interesting question. Where does this come from? How do we understand the consequences of the origins of these differences in cardiovascular health in childhood? We took several questions to heart, if I may say so, and proposed to the American Heart Association for one of their strategically focused research centers, this one for children, on early life origins of cardiovascular health, healthier earlier, as we have called our center. It brings together Northwestern Preventive Medicine, the Institute of Developmental Sciences of Northwestern, and the Lurie Children's Hospital of Chicago. The kinds of questions we were asking are instructive. They give us an idea of what we need to know about cardiovascular health in the population. What's the status of CVH from birth to age 8? How do we practically measure and monitor CVH in order to modify it in early life? Can we intervene to preserve CVH in early life? Does maternal fetal environment matter? What are the molecular mechanisms and signals of CVH loss or preservation in early life? And we could add response to interventions. We also, with our developmental science and Lurie Children's colleagues, posed the question how neurodevelopmental health and the child's social environment might interact and modify cardiovascular health trajectories. We'll have some answers to some of these questions as the center completes our work during this year. But equally important is what we already know. And a representation of that, summarizing what we saw earlier in comparing NHANES in adults and children, is we are losing the cardiovascular health we start with. If you ask what's wrong with this picture, it's far from the ideal. The ideal would be 100% prevalence at birth, sustained throughout life. Well, how could we get there? On reflection, it involves only two simple steps. The first is to stop the loss, and the second is to increase prevalence at birth. Getting to 100, one might say, is the goal of ideal cardiovascular health as a population measure. But how is it lost? Why does this happen? The life course progresses from ideal to intermediate to poor status, and it does so because of unfavorable change in the metrics, the behaviors and the factors from ideal to intermediate and from intermediate to poor, as we've seen from childhood through adolescence and through the adult years. We're not helpless, of course. We can improve, as American Heart believed, from poor to intermediate cardiovascular health and from intermediate to ideal cardiovascular health by bringing about favorable change in the CVH metrics, the behaviors, and the factors. This is all in the realm of primary prevention, interventions to alter risk downward to remedy what has already developed in the interest of preventing incident cardiovascular events. This strategy was first articulated perhaps most clearly by Jeffrey Rose in 1981. In the high-risk preventive strategy, he said, we go out and identify those at the top end, give them some preventive care, but, he noted, this strategy offers only a limited answer to the community problem of heart disease. We're therefore driven to consider mass approaches, he said. Potentially more effective, ultimately the only acceptable answer is the mass strategy, subsequently called the population-wide strategy. So here was his concept of primary prevention, two complementary approaches, high risk and population-wide. It's inescapable to note that this is, in many ways, and many of you would clearly agree, is a Sisyphean task. It's difficult to get to the top. If you relent, you slide back, and worse, there are generations behind, ready to enter on the same path. This cannot be the whole picture. What's the alternative? Another view has been termed primordial prevention. This introduced by Tom Strasser in 1978, professor of medicine in Budapest, then at the Cardiovascular Disease Unit at World Health Organization in Geneva. He said real grassroots prevention should start preserving entire risk factor-free societies from the penetration of risk factor epidemics. Here lies the possibility of averting one of tomorrow's world health problems, he said in '78. He wanted to propose two alternative terms, protoprophylaxis or primordial prevention. To the best of my knowledge, protoprophylaxis has never taken hold, but primordial prevention has. So let's add primordial prevention to the picture that we've already seen. Where does it go? It's represented by healthy gestation, healthy development, healthy aging, with the potential to increase ideal cardiovascular health prevalence from the beginning and to sustain it throughout life. In this figure, then, we have primary prevention and primordial prevention complementary strategies that together may help us get to the common goal. What's that goal? Well, American Heart put it very concisely in 2016 when they announced one brave idea termed a moonshot project to end coronary heart disease and its consequences. I'll underscore, to end coronary heart disease and its consequences. This was a challenge to investigators around the world to develop a proposal for a single $75 million project to achieve this goal. To us, it seemed clearly to call for an endgame strategy. An endgame strategy with a time and a target. Now, there's precedence for this. WHO, World Heart Federation, United Nations Sustainable Development Task Force have all set time-directed specific goals. Reduction in the proportion of deaths in the total deaths from non-communicable diseases and from cardiovascular diseases. WHO, 25% reduction by 2025. World Heart Federation, the same for heart disease and stroke prevention. Sustainable Development Task Force, reducing NCD mortality by 33.33% by 2030. We see a pattern of beginning to take a long-range view of the time required to achieve quite aspirational goals. So our view of the cardiovascular endgame was the need first to establish some strategic priorities. From what we've already seen about the natural history of cardiovascular health, this will not be surprising. We should increase the prevalence of ideal cardiovascular health. Make this the societal norm, not the pride of having survived your bypass. We should promote ideal cardiovascular health from the beginning of life and preserve it to middle age and beyond. And we need to set an interim target and timeline to sustain the needed action and to catalyze the work already in progress in this direction. So what should be the prevalence of ideal cardiovascular health as an interim goal and target? One could say 50%, or perhaps better. Promoting it, preserving it to middle age, how long? Let's say to age 50 at least, where we see the long-term benefits shown by that Framingham 2006 paper. We should set an interim target and timeline. How long should we allow for these fundamental changes to develop in our society and one could say globally? How about 2050 or perhaps sooner? Hence, 50 by 50 by 50, not 25 by 25, not 33 1/3 by 30, but 50 by 50 by 50. So what does this look like? We've already seen the picture, but we'll summarize it here. First, we stop the decline. 50% prevalence of ideal cardiovascular health through at least to age 50. Second, we increase prevalence of ideal cardiovascular health at birth to 100% and keep it there. Getting to 100, you could say. This was discussed in a perspective published in Circulation in 2018. And some details of the argument and the prospects are addressed there for your reference if interested. So what are the next steps to make this real and practical? First, we need to continue and expand the research. Modeling possible futures is one idea to get from 2020 to 30 to 40 to 50. What will be changes in food production and distribution, for example? And how would vicissitudes in this progress affect our efforts to increase population prevalence of ideal cardiovascular health? We need to continue the development of policies and programs and practices in both primordial and primary prevention. For example, implementation of the cardiovascular health growth curve, the concept of broadening the time-honored height, weight, BMI growth chart to include the 7 metrics of ideal cardiovascular health and monitor them from the beginning of life through childhood, adolescence, and into adulthood. Rapidly deploy and evaluate ongoing advances in technology, which continues to move rapidly and may have incredible new opportunities hard to foresee at the moment. Finally, and I want to emphasize the importance of catalyzing communities of all kinds, building on the current momentum, such as through a transformed public health action plan, the document published in 2003, updated subsequently, but perhaps ready for a transformation into application more fully of the concept of ideal cardiovascular health. So who is to do it? A wide range of researchers, thought leaders, and health practitioners developing of these new technologies, and community leaders and partners. And here I want to close by calling attention, hardly needed for this group, to San Diego County, California. Live Well San Diego has the mission, according to Robert Wood Johnson Foundation, to create a wellness system, ensuring individuals, families, and communities in San Diego have access to all they need to create a lifetime of health and wellness. Their aim, as a first step in the journey to divert the focus from disease to wellness, starting with the achieving ideal cardiovascular health across the lifespan through prevention, education, and treatment. The end game is already in progress, and this is strong evidence in right care in the Bay Area, Sacramento, Silicon Valley, and San Diego of work that's already in progress, momentum underway. And we should mention communities of other kinds have we an opportunity in our later conversation. But it's also worth noting RWJ in their report on the Culture of Health Initiative's Sentinel Communities says San Diego County is considered a national standard for collaborative community health planning. Again, reinforcement of the momentum already in work, in progress. So I've heard in conversation the expression getting to zero, and I've had the opportunity recently to reread the Health Affairs article documenting the impact of Be There San Diego on events from cardiovascular disease, acute MI, in San Diego County. The paper includes reference to what is termed an audacious goal of making San Diego the first heart attack and stroke-free zone in the country. Truly, that would be getting to zero. And what I'd like to suggest is it's time to begin our concerted effort to bring primordial and primary prevention together in this task. When does this begin? Well, the clock starts now. Thanks.
Thank you, Darwin.
Look forward to our discussion.
Darwin, thank you so much. That was terrific. So we are going to come back and have a lot of opportunity to interact with Darwin in the second hour of today's meeting. But before we do that, I have the opportunity to introduce Dr. Janet Wright, who is currently the Acting Director of the Division of Heart Disease and Stroke and Prevention at the National Center for Chronic Disease Prevention and Health Promotion. Dr. Wright has had a very distinguished career. I think many of you know her and had an opportunity to interact with her through her leadership in the Million Hearts campaign. She has returned to CDC after working in the Office of the Surgeon General as the Acting Director of Science and Policy. And in that role, she did all kinds of interesting stuff, including overseeing a report on marijuana and the developing brain, 2 Surgeon General's reports on smoking cessation and community health and economic prosperity, and 3 Surgeon General's calls for action on hypertension, maternal health, suicide prevention, and so forth. She's won all kinds of awards and has contributed in a remarkably wide number of areas. I also want to say that although I'm certain that Dr. Wright doesn't remember this, but she's not a stranger to the Right Care Initiative. When I was working at the NIH, we got her to come down to my office in the basement of Building 31 to actually interact with Right Care. It's an interesting story at the time. That something had happened in the Department of Health and Human Services. There was somewhat of a scandal and we weren't allowed to travel any longer. This was before Zoom. And so our office actually invested in something, a Zoom-like technology that allowed Dr. Wright to parachute into a Right Care meeting in California. So Janet, thanks so much for taking the time to be with us today.
Thank you so much, Bob. It is an honor and a privilege to be back in the Right Care family today. And I just want to also acknowledge the jewel, the prize, the treasure that is Hattie Hanley. I know we all feel the same way. And I am also so glad to connect again with Tony DeMaria, as our roots go way back. And Bob, I do remember that basement and have enjoyed every interaction I've had with Right Care. I will say too, I am not in DC right now. I am in Colorado because my second born is expecting her second born in the next couple of weeks. The topic has been a selection of names. And I have to tell you, ever since I first heard it, Darwin Labarthe has been one of my favorite names. I mean, it's the name of someone in a novel, right? You can't get a better name than Darwin Labarthe, and he lives up to his name. I will say, sitting in the division, even as an acting director, Darwin, your name is still said with hushed tones, and everyone thanks our lucky stars that you set us in motion in the Division for Heart Disease and Stroke Prevention. So thank you all very much.
The name is in the public domain. Feel free to use it.
Well, I think it's going to be a girl, so we'll have to work on that. But
it could be done.
So again, we are going to really change gears. When Maddie asked me about joining today, she asked me for a CDC perspective. And I'm not sure I'm adequate to convey that, but what I will tell you from the agency standpoint, what I'm so excited about is the voice that is now given to the importance of addressing health equity, social determinants of health, including racism, and doing what the agency has always done, focusing on eliminating health disparities, but with a great deal of more energy and intention, and I believe action. So it's a very exciting time to be part of the CDC family, and I think an exciting time to be in federal service. I'm going to cover ground that you all cover every day, and the lessons that I carry, I mostly learned at your table and through very generous efforts. I look across the number of people just whose names I can see, and I remember our conversations. What I want to tell you is that in my 2 years in the Office of the Surgeon General, I went on that detail really at the advice of senior leadership at CDC in hopes of implanting and embedding, infecting, if you will, the department with a concern about cardiovascular health and the prevention of cardiovascular events. And the idea was that if I was sitting in the Office of the Surgeon General, maybe there would be an opportunity to be in rooms and within earshot of people who could help us invest more deeply in the things we know will create cardiovascular health. Time will tell whether that was successful, but I wanted to show you 4 slides, not because any of the facts are new, but because I made them and I carried them into every conversation that I had in every room where there was an opportunity. The first is the one you're seeing now with the basic facts about hypertension. I wanted to boil down my elevator pitch to just these 5 bullet points. And I will tell you something frightening is that what we all know as common knowledge was not common knowledge. And I believe there were individuals, and I'm talking mostly career people rather than the principals, who were learning about this for the first time and who started to see opportunities for them to contribute, understanding that it will take a long time for us to get our arms around control. And after my Million Hearts experience, I have road rash from trying to make fast progress. So I'm completely with you, Darwin, taking the long-term view. So this was slide number 1 in my pack. Megan, if you'd advance to the second slide I carried around in my pocket, and this one is just terrifying. This is the one that keeps me up at night. It's 35 to 64-year-olds. I know you all have seen this before. This is not just cardiovascular events. This is cardiovascular mortality, both heart attacks at the top and stroke at the bottom. At the county level, and basically the red zones are showing an increase in cardiovascular mortality in our workforce, in our parents, in our caregivers. This is an extraordinary motivating slide. Next slide. I want to send off alarms. This one also is alarming. I chose African Americans and Blacks to feature, but as you all know, there are disparities in other individuals who are of color. But again, these you know well. One thing that is getting increasing attention now, thank goodness, is the disparity by race and ethnicity in women in and around the time of pregnancy. So I'm really happy that there was work done in the previous administration. It's clearly a priority in the current administration to begin to improve maternal health and ideally health for women across the lifespan. Next slide. The fourth in my set was this slide showing a mapping tool that CMS uses to look at the cost of care. Complicated slide, but basically this one shows in the darker areas show where the cost of care for African American or Black Medicare fee-for-service beneficiaries is higher than compared to all beneficiaries overall in the total cost of hypertension care. Again, trying to help people understand that this largely controllable condition is claiming lives, is hurting people, and we could get our hands around it with some concerted effort. So next slide. I was delighted on October the 6th for the Surgeon General, Dr. Adams, to release his call to action to control hypertension. Again, there's nothing in this document that you haven't seen or contributed to. Your research is referenced here, as are your very specific, tried and true, road-tested strategies to improve hypertension control. But clearly, we need to do something different, because what we are doing and have been doing is not enough. We know that control rates nationally are slipping after decades of improvement. Multiple reasons for that, as again, you all have known and published. But what happened with this call to action, in a moment that I'll never forget, every morning for about 20 minutes, the principals gathered for a COVID call, and each of the principals updated each other to the Secretary of Health and Human Services on the status in their particular part of the COVID pie. I was surprised on that call to hear the Surgeon General say that today I'm releasing a call to action to improve hypertension. And in about 30 seconds, 90 seconds, he made the case on why, yes, even in the midst of a pandemic, this call to action was an imperative. Connecting, of course, that uncontrolled hypertension causes these events, largely preventable, but making people less resilient and more vulnerable to all kinds of health threats, including this novel coronavirus. I'll note that self-measured blood pressure monitoring is one of the strategies called out in that call to action. And I will deep dive into that in just a moment. So next slide. Oh, so my point here is that on this call, which only lasted 20 minutes, the SG received 3 or 4 texts from other principals saying, hey, I want to make sure you know what we're doing in hypertension control. And as he was sending these to me, he said, I'll never forget, there's a lot going on in the department around hypertension control, which was music to my ears and not unknown to me, but there was no place, no time, no charge for these agencies to come together and try to intercalate their actions so that we could actually make progress. So I'm going to just chat with you for a moment about what is now looking like very promising a federal response. I'm not saying that this is going to change the world, but I do believe that there are people in federal government, long-term federal service, who have been working on this or want to work on this and can see how through a collaboration just within the federal agencies, we could contribute to progress. So this is the Leadership Council's currently its purpose and its charge or vision. This council has come together now 4 times. It's getting its legs under it and discovering who it is and what it will do. One thing I'm really, you can tell I'm really excited about this, but one of the reasons is that we're not going to create a 5-year, 10-year strategic plan. We're going to do tactical actions. We're going to lift up those actions that we think we can make headway on now, given the current environment and the opportunities we see, and what we've heard from the private sector about where people are stuck. What would actually help us get unstuck? And how can we keep health equity and the reduction of health disparities in our central focus? Next slide. Shows the agencies that are already in action. By already in action, these agencies have been working on hypertension for a long time. The idea here is, what could we do if we came together and shared a common agenda, or at least a few priorities, given a sort of a 12-month focus? What could we get done? It's an open table, so we hope to get more agencies. And I promise you that as soon as the HHS agencies, we could get our legs under us, we've already discussed that we need DOT, we need USDA, we need HUD to really get at the social determinants. We have to get upstream from the department, as well as all of the things that are under the wings of agencies in the department. Next slide. So we've been trying this, Leadership Council has been trying to get a visual on the interactions between these massive forces and how hypertension control plays a role in it. This is very much a working document and it's for internal use. But the point is, there is obviously overlap in health equity and hypertension control, overlap between the COVID, not just the insults to the cardiovascular system, and the distraction, if you will. God bless Walter Barnes. His quote gave me, in the context of COVID and heart health or cardiovascular health, I feel like those two are competing against each other, because right now in CDC, our first job is to respond to the COVID crisis. And so lots of our staff have been pulled away. Those are challenges in executing our mission, our cardiovascular mission, but there are also a lot of opportunities that are coming up as a result. And one of them is the focus on how harmful these preventable events are to individuals in terms of their resilience. Next slide. So I just will share with you, this is very much a working draft, but we're dividing our work or characterizing our work in these 3 buckets, obviously detection, control, and prevention. Oddly, for most of us, prevention is listed last, because the things that the government will do to help prevent, they're all longer term. We don't have as much development around those things as we do around control and around detection. So I won't say that these are written in stone, but if you hit click once more, Megan, I will tell you that there is enormous interest in advancing the practice of self-measured blood pressure monitoring. I know that you all have that on your plan as well, and I'm deeply influenced by that. We know that the American Heart Association and the American Medical Association are all in on advancing SMBP. CDC is as well, and particularly led by the division and a lot of the work that's been done in Million Hearts. So I just will say that I believe we're in this together and hope we can continue to learn from each other. And what I mainly want to do, and I don't want to go right up to the deadline here, is to signal that I would like to know where you all and all of the things that you touch, where you are stuck. I think I have a good list of to-dos related to advancing SMBP, but I need to continue to hear from you. Next slide. I'm going to zip through these. I know what this is. Next slide. You know what this is. Next slide. Next slide. Yes, this one. So this is at least a starter list of where we're stuck with making self-measured blood pressure monitoring available to anyone, anywhere across the country, affordable for individuals and sustainable for clinical practices. On the right side, you see the opportunities. I won't read them, but the slides will be available to you. I will tell you that over the last, I think, 9-10 months, there's been tremendous progress in tackling some of these challenges. We still have a long way to go, but there is headway. For example, there are new CPT codes that people can get reimbursed for the service. The performance measure, hallelujah, was altered to accommodate for out-of-office readings. The AMA did remarkable work getting a validated device list published, and now trying to get more and more device manufacturers to list their devices. A huge one, of course, is monitor availability. Why is it that devices to check the blood sugar are covered and devices to check the blood pressure are not? Anyway, we've got good work to do here, but at least I feel like there's a clear roadmap. Next slide. So I wanted to share this video. I won't for time, but each of these videos is about 3 minutes long. I watch them on a regular basis. To me, these are both videos taken from federally qualified health centers delivering care to populations that are challenged in multiple ways, and yet they have managed to implement SMBP programs and overcome all these obstacles. And both of these stories show you what it can mean to an individual and to a family when all these things have been tackled and successfully managed. So please look at them if you have 3 minutes to spare. Next slide. A couple of articles backing up the progress that's going on in some health centers around the country. Next slide. These things give me hope. This is an enormously exciting initiative that is now underway. It's part of HRSA, the Office of Minority Health, and the American Heart Association, with technical assistance from AMA and Million Hearts, and basically 90 million going to 496 health centers, DC and the territories over 3 years to accelerate the implementation of SMBP. Next slide. So I included a slide with a lot of resources. These have all, as I said, been road tested. If you are considering implementing SMBP or accelerating your program or test driving the way you're doing it against some of these other tool collections, please visit any of these. Next slide. I'll just say that this one was recently posted on the web. It is an online e-learning module, set of e-learning modules based on the Kaiser Colorado program, but then applied in a federally qualified health center in South Carolina to make sure that it could work in systems outside Kaiser. And all of that was sort of translated into a toolkit. There's a PDF, but there's also, as I said, these modules, all free, available on the website. I think the next one's my last slide. Yes, and in terms of advancing SMBP, in the Surgeon General's guide or a call to action, there's a sector strategy. So for payers, for employers, I would love to hear from you if the thing that we think you can do, you can't do, because we need to revise our ask. There is an SMBP forum that's now about 400 people. But if you have tips to share, expertise to share, or you're interested in that, please join. These are quarterly meetings. You can sign up on the website as is listed there. Last slide. Yes, And this is my email address. Please get in touch with me and let me know where you're stuck or what you would suggest so that we can make this advance in care proceed rapidly, because we do believe it will be a great addition to achieving hypertension control in the country. It's not the only thing we need to do, but we think the time is right, given the focus on equity, the opportunity to expand broadband, to reach rural and urban populations, and to prevent events and get to zero. Thanks very much, Bob. I will turn it back over to you.
Thanks so much, Janet. And we understood that you had a hard stop today at 1 o'clock California time. So we'd like to honor that, unless you had any parting comments, but.
Thank you. I want to stay part of this family, the Right Care family. So please keep inviting me to listen. And if this other thing gets done early, I'm going to log back in.
Thanks so much. Thanks so much for being with us.
Thank you.
So we have an opportunity for an interesting sort of new approach to our meetings. We're going to have a lightning round with some distinguished experts, and I think we ought to just jump into it. And I think that some or most of these people will probably have questions for Darwin, and then we'll sort of go from that into the general discussion. So first, I'd like to introduce Dr. Tony DeMaria. Tony was a colleague of mine when I was at UC San Diego. He is regarded as the best clinical cardiologist, at least among all the people that I talk with. And Tony's had a very distinguished career. He's a past editor-in-chief of JACC, the Journal of the American College of Cardiology. He's also the past president of the American College of Cardiology and also the American Society for Echocardiography. And Tony has even served as the host for cardiology updates on Lifetime television. So Tony, it's good to see you, and we look forward to your comments.
You are muted, Tony. And we're so happy that you're joining us from San Diego and from all around the country and the state. Thanks, Bob, for the introduction. Hi, Tony.
Hi, Hattie and Bob. It's a pleasure to be here. It's difficult to follow two spectacular talks like that, but Hattie asked me in 10 minutes if I talk about something that's quite a bit different than what we've been hearing, and that would be the use of statins or other lipid-lowering drugs and how they may fit in. Clearly, Darwin is right. The solution to the problem is prevention, but there are some people who are dumb enough to pick the wrong parents and wind up with high cholesterol, even if they follow all the rules. And of course, there's a lot of us who sin from time to time. And so there clearly is, and I believe always will be, a role for medications in reducing the risk. So if we can go to the next slide, I'm going to rapidly go through some slides. An important concept that our two previous speakers really all made, which was that there is a very high risk group for coronary events, but it's relatively limited. It's that group in red at the top of the pyramid. However, the individuals in society who are at relatively low risk represent such a huge group that, in fact, if even a much smaller percentage of them have an event, it will still in aggregate result in a larger absolute quantity. And so what we really need to be doing is to treat the whole pyramid and not just the focus at the top. Next slide. So for those people who have disease, there's no question that lowering cholesterol with whatever means you can use is very effective at reducing coronary heart disease events. And this is a slide that's been shown many, many times, indicating, number one, that you can reduce events by reducing low-density lipoprotein cholesterol. And in fact, the more you reduce it, the more you reduce events. Next slide. Okay, now statins are a very effective way to do that. And people often ask me, well, are there real data? Well, this is from the cholesterol trialists. So all the people who did trials got together, put all their data together. And in fact, 423,000 patient years of follow-up have shown that for every 39 milligram per deciliter reduction in LDL, you have all these wonderful things on the slide. Most importantly, a 23% reduction in major cardiac events. And I'd focus your attention on about the sixth bullet point, that this benefit is not influenced by baseline LDL, regardless of how low the baseline LDL was to start with, the benefit accrued. Next slide. So statins are good, but in fact, we have other drugs that can add to that. This is the PCSK9 inhibitors, and this slide taken from a trial of evolocumab, which is one of those. And you can see there's another couple 3% benefit in terms of reducing the incidence of events if you add these drugs to maximal statins. Next slide. So we have a lot of good things. Now, this is one of my favorite slides from the BMJ, and it's taken from Denmark. Now, Scandinavia is amazing. Every single citizen is in the healthcare system, 100% of citizens. There's no enrollment bias. And I'd focus you on the curves that show the relationship between lipid lowering and mortality, that in the absence of lipid lowering, at an LDL reached their nadir at an LDL of 140 milligrams per deciliter, but with lipid lowering in the bottom, you see the entire curve has moved to the left. The entire curve has moved over, and optimal is at 100 milligrams per deciliter. So that's a number I keep in mind. I think that's very handy, that 100 milligrams per deciliter ought to be something that maybe we ought to shoot for. Next slide. For primary prevention, again, the curve exists, the same thing. The lower the LDL, the lower the events. These trials as primary prevention or somewhat limited, Jupiter probably being the best, but nevertheless, I think clearly supporting the concept of a lower LDL. Next slide. Okay, so there's pros and cons of lowering LDL targets. There's not many cons in terms of having an LDL target. They're very controversial, and that's one of the reasons Hattie asked me to talk about. There's a number of pros. LDL targets are of value in high-risk groups and independent of LDL levels. They've been used in virtually all the trials. There's additional therapies that have been shown to be effective to statins, and so there's some rationale for having an LDL target. Next slide. One can ask, I think we may have skipped a slide, but what about side effects? And this is one slide to say that actually statin drugs are amazingly free of side effects, as are the PCSK, as are virtually all the drugs. And in fact, it's been shown that in studies where people are given statin drugs blinded to the knowledge that they're statins, that in fact, oftentimes they don't experience the side effects that they reported when they thought they were taking statins. Next slide. So these are the guidelines, our current guidelines, and I think they're really excellent guidelines. And they emphasize that LDL should not be the only determinant in terms of deciding to treat someone. One should take an entire risk profile into account. And I think that that's very important. Is there additional hypertension? Do they smoke cigarettes? Family history of premature coronary artery disease, it's diabetes, etc. But if one takes these guidelines and looks at them, you'll see in the red box I have, if the individual, by virtue of looking at risks, is judged to be a sufficient candidate for statins, then these are the recommendations for the cholesterol LDL levels from 70 to 190. Now, if they say that 71 LDL would put you in the range of being a candidate for treatment, it strikes me that indirectly the guidelines are recommending that 70 is probably a reasonable level. Clearly, that's not been documented. The important thing is that no cholesterol lowering trial has ever been done to a target, so that those data don't exist. But this is a suggestion that 100 might be a good LDL level. LDL 70 might be even better. Next slide. And this is my last slide, I believe it is, and reflects my bias. This is a slide that shows cholesterol levels gathered as best they could be in different groups. Hunter-gatherers on the top, wild primates, wild mammals. And you can see cholesterol levels there are nearly always below 130. But in modern humans, cholesterol levels are up around 200. So that, maybe nature is telling us something. Maybe nature is telling us that in individuals who are behaving in a natural lifestyle way with a natural diet, that coronary disease would be very unusual. And maybe we were meant to have cholesterol levels in the same range. And if I choose to believe that, then I think we have really good medications that can help get us there. So I'll finish there and turn it back to you, Bob.
Thank you so much. And so the next person is Dr. Oliver Brooks. Dr. Brooks is the immediate past president of the National Medical Association, and he's also the chief medical officer and past chief of pediatric and adolescent medicine at the Watts Healthcare Corporation. Dr. Brooks has also been very active in LA Care, which I think those of you that are familiar with LA is a remarkably successful health care delivery program in Los Angeles. So Dr. Brooks, thanks so much for being with us.
All right, thank you very much. So I want to really thank the two presenters. Darwin Labarthe, that was very interesting with the broad perspective, the long-term perspective, and then the presentation by Janet Wright regarding tactical actions, because we need to do both. We can't be forest for the trees, focus tactically, or look at the broad picture without having any structure. So the question I have to you, Dr. Labarthe, is this. I'm a trained pediatrician, and you presented very compelling information on your graph that from 0 to 8, there is a bump up for risk. So My concern is it's not that high of a bump up, but it's there. Is some of that genetics, which is obviously the answer is probably yes. But my more general question is from 0 to 18, what's the role of the pediatrician? You listed a number of people who would be involved, and one of them were doctors. But we as pediatricians, I mean, we measure blood pressures and we do screen for cholesterol per AAP criteria, but we're not deeply involved in cardiovascular disease unless it's truly pathologic. So what would you say the role is for someone like me, a practicing pediatrician?
Thanks, Oliver, for the question, and I think it's a central one that merits a lot of discussion among people who are dealing with children as their patients, whether in pediatric or family practice or otherwise. One approach that I mentioned, the cardiovascular health growth curve, is something that we believe could be integrated into child care and could serve to identify departures from a favorable trajectory of cardiovascular health metrics early on and permit some adjustments to patterns of behavior and other factors that could be influential. We're working now to test what such a growth curve could be like in practice in Chicago. We have the opportunity through the networks of patient care in Chicago to enroll a number of practices which could be very, very helpful in implementing and evaluating this approach. The other thing I would say, Oliver, is that we look at the customary approach to screening as an approach really aimed at the high risk strategy. Its intent is to identify those who require intervention. If found, it's because they have already developed adverse profiles of risk factors. We prefer to think of assessment rather than screening, in which every child is assessed at every visit for cardiovascular health status. Those who are doing well on one or a number of the metrics would be encouraged, advised, assisted to support the behaviors that are working and given information, advice, tools, resources to improve those where improvement is needed. So this is, I think, the beginning of a conversation about how this works. NHLBI has, well, as actually the Division of Preventive Medicine at NIH has recently had a workshop about screening, and I've laid this out in some detail that screening is perhaps, what should we say, superseded by an outlook which is assessment, promotion based on the findings, and a cyclical pattern of monitoring the cardiovascular health trajectory as the outcome.
Thank you. And just really quickly, because this is lightning round, with focusing on the child, there may be a secondary benefit on the parents. You're looking at my child's heart, what about my heart? So I think that there also is a benefit in that. So thank you for your answer, Darwin.
Well, thanks for the question. And I would just add on that last point that the child becomes a parent. And if we are going to break the cycle between successive generations exhibiting the same risks and problems, we need to make incipient parents healthy in order to accomplish what we're trying to do.
Thank you.
Great. Well, thank you. So next we have Steve Chen. I think most of you know Steve if you're a regular Right Care participant. Steve has been very active with Right Care. He's Associate Dean for Clinical Affairs at the School of Pharmacy at USC and also a professor of clinical pharmacy and has just been a great contributor to all of our activities. So Steve, thanks for joining us.
Thank you so much. What a great presentation today, Dr. Labarthe. Thank you so much for joining us. If you have tips on how to make parents listen, I find that as I become the parent, my parents don't listen to me much. But my question, I'll frame it this way. I think Dr. Wright gave a great line, common knowledge is not common knowledge. And I bring that up in the context of both people, patients, and sometimes prescribers. As you know, we have an issue with many people having low health literacy, and unlike previously stated, not 100% of the US population is in a healthcare system, and that means many people rarely see a physician, and when patients leave a doctor's office or hospital, they don't always make the best decisions, and they're hard to track, they're hard to monitor. That's one issue, and the other that we're seeing quite a bit of is that some prescribers seem hesitant to tighten up blood pressure control or add statins when they're clearly indicated. And as much as the evidence which was shared today is overwhelming, it's surprising how difficult it can be sometimes to convince prescribers to make those changes. So my question is, in your opinion, Dr. Labarthe, how can we leverage community-based organizations to identify undetected or uncontrolled cardiovascular risk factors, similar to what Dr. Ron Victor did in barbershops here in Los Angeles, with Black Barbershop Program? And the second is, what thoughts do you have for overcoming treatment inertia for conditions like high blood pressure and statin use? And I'll just frame it with my one bias being, I think pharmacies are a very viable solution. There are 4 times more community pharmacies than Starbucks across the nation. I think they're highly underutilized as resources, both for screening and for improving drug therapy. So if you could please answer that, really appreciate it.
I'll give a response to the second question and then ask if you could repeat the first. And I would say that others in the room are far better experienced than I in addressing that difficult question about overcoming treatment inertia. I don't think I have a solution to that problem or even a suggestion that you all haven't thought about, wrestled with, and addressed in a variety of ways over the years. The answer I would give in the context of discussion of promoting ideal cardiovascular health is we would aim to prevent the need for treatment. But that's a long-range target, and treatment will continue to be needed. So along with Sisyphus, we need to develop more effective strategies than we have. But I think that problem, as you point to it, is a part of the reason why we have a lot to gain if we're able, in fact, to prevent the development of risk in the first place through primordial prevention. Now, that's a sideways answer to your question, which I understand, but I really defer to those in the room who are dealing with this frontline every day. The first question, if you wouldn't mind.
Oh, it was just any of your thoughts on leveraging community-based organizations to identify undetected or uncontrolled cardiovascular risk factors. And the barbershop example is what I shared from Dr. Ron Victor that he ran here so successfully in Los Angeles.
Yeah, I think an answer to that question, Steve, is that if we were able to implement the CVH growth chart that we've talked about, we would have knowledge of the course of development of the cardiovascular metrics through a child's development, early life, childhood, adolescence, and beyond. Would that help to identify those who are at risk? Yes. If we have more complete knowledge than I would say we have today about what those trajectories look like and what the determinants are of the variation in them. As I've said, we were struck by the fact that wide variation in the trajectories is already present at age 8. We used to be fond of saying naively that we start with ideal cardiovascular health and lose it from the beginning. We of course are more and more aware that there is not universal ideal cardiovascular health at birth either. And this takes us back to the maternal fetal studies, issues of healthful gestation and early development. In the long run, and I keep thinking in the long run, the opportunity to leverage what organizations are doing to recognize departures from the favorable trajectories will depend on establishing those trajectories in the first place far more widely than we do now.
Thank you.
Thanks. So the next person in the lightning round is Jim Duddle. Actually, Jim, I noticed on the screen it says Robert Duddle, and I want to say that I'm not sure where that comes from, but we Roberts are really pleased to have
Well, thank you. It is Robert James Duddle. I just went by my middle name for most of my life. At any rate, yeah, do you have my slides somewhere coming up? At any rate, what I was planning on saying, I'm going to pretty much scrap, but I am going to say, Darwin, I really like your idea of adding all of the cardiovascular risk factors to the child as he grows up, because I think there's three things. We got to know what to do. We got to know how to do it. And then the third thing I'm going to add is we have to be sure there's someone accountable for assuring that it happens and that it continues to happen. And so I'm going to give you an example of diabetes and what we worked with. And the standards of care of diabetes by the ADA has said, oh, there's three things we ought to do for sure, or ought to consider. One is lipid lowering agents, and thanks to the ADA and AHA, but also, and when we get to accountability, I think HEDIS really added a lot here. And that is that any person with diabetes over 40 should be on some statin, any statin. If they're over 50 or high CVD risk, one of the high intensities or Zuva or Atorva, and moderate or high dose. So we know what to do there. And that's like 50% of what we can do in the way of decreasing events. The second, though, is antihypertensive agents. The three types, the three classes. ACE-ARB could always be started first, but calcium channel blocker or diuretic could be started first. And all three could be added on top of each other until the blood pressure is 130/80. And so that's about a 40%. And the aspirin is less than 10%, about 7% decreased CVD risk and 7% bleed. So if you have CVD, that's high enough to say, okay, that outweighs the bleed. But ADA says patient preference. However, there's one study that just came out in New England Journal by Salim Youssef with a polypill. And he took a polypill with a lipid agent, the three antihypertensive agents in low dose, and one arm, and another arm he added aspirin to it. The only arm that actually hit clinical significance was the one where aspirin was added to it. So although I know a lot of people have said, it's a small issue, don't worry about it, that makes me not want to throw it out anyway. Glycemic control, metformin's been very good. As you remember, the UK PDS study back in London, at least 20, 30 years ago, showed that at the end of the study, metformin decreased, the metformin arm, there was decreased events to the 0.06 level, but every year thereafter for 10 years, they got down much lower, and they maintained the difference well over 10 years. So that's to start with. Now, with CVD in DM, there's all these new things. I'm going to give you a mnemonic to remember. It's the tide flows in. So if you have CVD and either congestive heart failure or renal disease, use a flows-in SGLT2 inhibitors, Impagla, Cana, DAPA, flows-ins. If neither, and weight loss is important, exenatide, liraglutide, or semaglutide. So let me just mention, now that we presented what to do, the how to do it was actually what we did inside Kaiser was saying, start the lipid agent, antihypertensive agent, and aspirin all at once. And actually, it really seemed to work. I think part of the reason it worked well was because we were monitoring all the physicians, feeding it back monthly for over 3 years, and they kept doing it. I think Steve Chen has showed me that if you just have African Americans go back to their doctor, you don't have them continuing to, or even to treat, not initially, and certainly not maintaining the intensity that you need to get pressure down. But when you add the pharmacist, as long as the pharmacist stays involved, it stays down. However, in one study where after 1.5 years, they dropped out, by 5 years, the blood pressure was back up. So now we're getting back to, you know, in assurance that accountability is done and someone keeps an eye on it. Now, when Janet Wright talked about measuring home blood pressures, this is great. It gives us a tool to do, but you still have to collect the data and you have to make sure someone stays on it. The way that that's been done in other parts of the world, Southeast Asia and Argentina, is they put a lowly health worker involved who doesn't know much about the disease, but they have metrics they have to hit and they have somebody checking them. And if they follow them for 5 years, the benefit stays and it gets bigger. So my contribution is yes, Darwin, we need to continue to work on the DPP idea of the diet, the lifestyle, and figure out all the barriers there. But we also then need to hold people accountable, both to the lifestyle and to anything else we do. And those are just my thoughts and comments.
Great. Darwin, did you have a reaction?
Only to say that it's clear that we are less than wholly successful in instituting and sustaining the treatment that we know will benefit the individuals who receive it.
Right.
And my response would go back to Steve's question as well about treatment inertia. A way to look at the problem, which will not be altogether revolutionary, is to consider what is it that differentiates those who are most successful from those who are not. What is it that works in their lives, context, in their situations that enables them to receive the full benefit of the treatment that's prescribed? This is further downstream than the broader issue of how do we know who in the population is in need of treatment, and we still have some barriers there. But I think better understanding what works well, what are the assets that make care most effective, I think that could be a helpful focus.
And that also pertains to the motivators that we could try to find. So thank you very much. That's an excellent suggestion.
Thank you, Jim.
Thank you, Jim. By the way, Jim, I have to say that I was just about to launch into saying all these wonderful things about you in the introduction, and you jumped right in. But,
that's okay.
But Jim is an endocrinologist who's been with Right Care right from the very beginning, and has had a really distinguished career, including being an investigator in the famous Accord study. And so anyway, it's been great to have you with us all these years.
Sorry to interrupt.
Well, I'll save it up for the next time. So I'd like to introduce Scott Flynn. Scott is another person who's been with Right Care from, as far as I can remember, right back toward the beginning. Scott is currently the regional medical director for Blue Shield of California, and he's a former U.S. Navy undersea medical officer with the Navy SEALs. He was with us actually when he was on the medical group side in San Diego before he went off to Blue Shield. And Scott, thanks again for being with us.
Thanks, Bob. Yes, before I joined the dark side, as you would say, right? On the plan side. So, Darwin, excellent talk. Learned some great stuff. But I had one question for you. When we think about social determinants of health and disparities and changing human behavior, it's a difficult thing to approach. And historically, you know, as a provider and also now with a health plan, we thought, oh, that was somebody else's responsibility, notionally the government's. But we've come to recognize that if we're going to get to our national goal that the Surgeon General said of 80% hypertension control nationwide, there is no way we can go from our lowly 47% to 80% without attacking those. So changing that baseline, getting folks up on there, like you talked about, the 2 ways to do it, enabling those folks to encouraging activity, getting folks off the couch, stop playing Nintendo or war games or whatever they're doing, addressing food deserts. Are you aware of any studies that show that there's a way to address this at the population level?
Yeah, that's an excellent question, Scott. Have these things changed? I would go way back to the example of the North Karelia program in Finland, which was stimulated in the late 60s, beginning 70s, by realization that Finland at the time had the highest coronary mortality of any country reporting to WHO at that time. There was a decision to undertake a local demonstration project in which the community leadership, political leadership, medical leadership, citizen groups would undertake to bring about all of the favorable changes that they could think of that would improve the situation. It had partly to do with primary care, but it also had to do with food production and distribution and pricing and social conditions more generally. The most recent evaluation of the success of that program, as described by Dr. Pekka Puska, some of you may know of, who was the director of the program before he became part of the Finnish legislature, was that among 19 factors that influenced the success of the program, the fundamental concept of social change was the principal driver. It bears going back to accounts of the North Karelia program and how that actually operated. But I think that's a very worthwhile perspective. Not recent, but classic, and I think potentially very informative. No question that these are deep and pervasive issues. Racism along with that. One suggestion that I have, and I'd ask you the question, Scott. When you speak of social determinants, what do you think of?
Yeah, the first thing that comes to mind is your zip code is more important than your genetic code in determining your lifetime expectancy. And that really goes back to, poverty as a disease. And that's what it brings to mind. And then when you think about the disparities, who tends to end up in those economic zones and why, and how do we get out of that cycle?
Yeah, well, I appreciate that. And it supports a question that I've had in mind for a good while. And that is, when people speak of social determinants, are they or we not typically speaking of the obstacles, the hazards, the negative factors of the personal, social, economic, physical environment that create obstacles to good health. Suppose we look the other way and say, what are the social assets, the community assets that enable some to do very well? And I think in this connection of the work of Herman Taylor at Morehouse in Atlanta, who is interested in the question of resilience. How is it that some members of the African American community do quite well, despite the fact that they occupy the same environment as others who are seriously impaired in their functioning, in their health, and otherwise? I think to the extent we can try to consider the positive aspects of social determinants. What are the social determinants of healthy? we may have insights that will be helpful to us in order to, you know, in the old bon mot, accentuate the positive. And I don't mean that to be a glib answer, but
I certainly didn't take it that way. And because it's really okay if we can find out what the levers are, then how do you address the levers, right? Yeah. What part of that do you poke to try to help get it better? Because again, you know, definition of insanity, doing the same thing over and over and expecting a different result. 47% national hypertension control for the richest country on earth doesn't make any sense at all.
No. Well, I'd welcome the chance to talk further with you about this, because I think it's, you know, it is a fundamental question that has to be addressed. Perhaps in the wake of our experiences over the last year and more, we will find ways to be much more successful in dealing with these deep-rooted problems. But it's a heavy lift, no question.
Great.
Thank you.
So, Darwin, I want to introduce another key member of our Right Care community. Joe Skye is a cardiologist. He's chief of cardiology and medical director of the Heart, Lung, and Vascular Center out at Travis Air Force Base. And Joe has been a great contributor to Right Care. He has a remarkably broad perspective on these issues as a practicing cardiologist, but also someone who's become very interested in blue zones. He's has been a flight surgeon and has become very interested in lifestyle and how that affects cardiovascular disease. So Joe, as always, it's good to see you.
Thank you so much, and wonderful talks earlier today. And I just want to say to Dr. Labarthe, I think having been at the School of Aerospace Medicine at the Air Medical Consultation Service, the lessons from North Karelia were certainly used by the Air Force to try and change the environment around at least our highest performers, our pilots. And of course, it's a great inspiration that Dan Buettner uses in his models for the blue zones in other communities. And all tied into that, I'm only going to show some slides today that are really just excerpts from a colleague of mine, another Air Force cardiologist, Dr. Davenport, gave a Right Care presentation in February of this year. So the full talk is available. But just going to give just a quick overview of coronary calcium and how it's been used to make flying safer for all of us, and how I believe it can be used clinically to make all of us safer, at least from heart disease. And if I could have the next slide. So starting in the 1960s, when people like Dr. Cooper, who went on to found the Cooper Institute, were flight docs at the School of Aerospace Medicine, they were challenged with a dilemma, which was that a recent analysis that was published in 1971, a recent analysis at the time published in 1971, showed that the #1 medical reason for aircraft mishaps across commercial and military aviation was heart disease. And so the challenge was an all call across the scientific and medical community. How do we find a way to make our pilots safer? And so the aerospace medicine community really had to rely on the best evidence-based medicine they could, but then they also needed to use observational data, because we had to immediately start promoting safety and occupational safety as well as clinical outcomes. Next slide. And so starting around 1980, the Air Medical Consultation Service started a registry to include every non-invasive study as well as the results for angiography, and reached about 1,500 pilots between 82 and 1993 in this database. And as we know, because of the mathematical rules of statistics, if your pretest probability is low, none of the tests perform that well, but coronary calcium became the most reliable tool, and the consultation service was actually using a precursor to the CT version of coronary calcium. It was something called fluoroscopy, which basically detects just on a live cine view on the cath lab table, you could see whether there was coronary calcium in the arteries of the heart. And using this early version of coronary calcium detection, they were able to create, my mentors were able to create a way to create a logarithmic regression equation that allowed us to predict very accurately whether or not someone was safe to fly. And by 1993, there was enough data to start using these equations and predictors prospectively. And we did that for 3 years. And then we've been using it operationally ever since. And the coronary calcium has been a key component of flight safety, both in the military and as many of you know, the FAA and other air forces of the world use a similar approach. Next slide. After the aeromedical community started using coronary calcium in the military, we also started using it for our special forces and people that would deploy. Just in the sense that it gave us an opportunity to make sure that we could keep them as safe as we were our pilots. And then interestingly enough, some physicians at Walter Reed, just around the time that I came to the Aeromedical Consultation Service, wanted to use our protocols and start offering it to a wider audience of patients. Next slide. And so Dr. Valines, almost 15 years later, after they had studied several thousand patients, published this. And this is an interesting group. This was mostly retirees and high-ranking Army officers and enlisted that were offered coronary calcium, all asymptomatic. And at the time, it was set up like ours was, sort of an occupational registry, not necessarily with the intention to publish. So when it was published, it was a retrospective look at the outcomes. And next slide. As most of us know, the results confirmed what we had anticipated and how we had used this in the flying community, which was that if you don't have coronary calcium, your event rates are low, and you also, as expected, are not likely to benefit from therapy. But if you had coronary calcium, and the more coronary calcium you had, thankfully, most patients were put on statins because the instructions given to the patients were similar to what we had been telling the pilots all along, was that coronary calcium was a marker of heart disease. So while there wasn't a protocol that they had to be treated, most of them were, and they achieved a benefit from getting statins, correlating with the amount of coronary calcium. Next slide. And so just to summarize all of this, I would like to just remind everyone of the history, and the full talk from Dr. Davenport, my colleague, was in February. It's on the Right Care website, where we show the data that our goal was to make the pilots safer than the airplanes, which meant we had to reach a 1% goal, which translates into 1 event per million flight hours. And we have one of the most open databases in the world. The Air Force has never had a single mishap known to be caused by a cardiac event. And as you know, all commercial airlines have 2 pilots because we cannot make it safe enough, even with the healthiest individual, to fly single pilot. But with that, the United States has not had a known fatality because of coronary vascular disease, because of this type of flight safety that we've used. And the Air Force, over the decades, we have achieved incident rates well under 1%, sometimes as low as 0.3% per year, using coronary calcium as a screening tool to protect the safety of flight. And with that, there was a question from Dr. Zelikoff in the comment section. Could I go ahead and answer that now regarding coronary calcium?
Sure.
So Dr. Zelikoff, I'll leave your first question alone, but your second question I liked. And that is, when we see athletes that have increased coronary calcium, does this mean we really shouldn't measure the coronary calcium? Another Air Force colleague of mine was one of the authors on that study that looked at the high performance athletes and the coronary calcium. And in discussing the reasons why we think some athletes may have high levels of calcium, there's some concepts that come into play. If you're an athlete that's burning a lot of calories and your food is not as healthy as perhaps it should be, there may be this concept of efflux of the lipids that's leading to excess deposit because you're burning so many calories. And so perhaps it would be useful to know, although this is all theoretical, that if you do have a coronary calcium score that's elevated relative to others, that you could change that. The other thing is that it could still direct a more aggressive treatment, especially in an athlete. And then as we learn more about cholesterol efflux, there may be something there as well. So I hope that's what you meant by that question. I think that there's a lot that we still don't know, but I would support measuring coronary calcium in high performance athletes, maybe even more than the average person.
I think we should go ahead and move to Dr. Stock, who also wants to talk about precision cardiology. Unless, Joe, you have a question for Darwin before we move forward to the next co-leader of our Bay Area chapter.
Oh, no, let's hear Dr. Stock's.
Great. So while Dr. Stock's getting ready, Evelyn Stock is one of the co-leaders of the Silicon Valley group in Right Care, and she's a practicing clinical cardiologist at UC San Francisco. It's just been a wonderful colleague in this effort. So, Evelyn, are you with us?
Yes, I am, Bob,
Good
and glad to be here with everyone. And this has been a remarkable session. I have learned so much hearing you all. I'm going to talk about precision tools, and it's going to be a very short presentation just to provoke thought. Precision tools, as a molecular cardiologist, I would consider myself a molecular cardiologist because I've always been fascinated by mechanisms of disease. I've studied hormonal mechanisms that allow the cardiovascular system to protect itself from the effects of hypertension and other nauseous influxes. And as I have developed my career, I've seen the emergence of all of these powerful molecular tools, imaging techniques, social, psychological evaluations of people, environments. How do we put all of this together so this poor individual who's someone accountable, right, for your health has some tools, or as researchers, we can leverage all of this amount of information. And I found this very, it made me very happy to find, I didn't know about the Institute for Precision and Cardiovascular Medicine. It's an American Heart Association effort, created a new model for bringing together science and technology to drive these breakthroughs in cardiovascular and brain health and disease. And as soon as I found this, I registered and joined this wonderful collaborative. Next slide, please. So I really like these quotes. In order to prevent heart attack and stroke, we really need to understand how atherosclerosis develops and how it evolves over time. And everyone has been involved to some degree in this. And we need to looking beyond conventional factors is essential for accurate stroke and heart attack prevention, especially given that stroke and heart attacks are preventable. And unfortunately, its first sign may be fatal. Next slide. So I want to bring to your attention these two cases that just show us a little bit about how I want to share my thinking with you. We think from cases, we say that the clinic or the clinical cases inform the bench to bedside research, right? That's how we start. So these two cases, case number one, an unfortunate 19-year-old who presented to our UCSF lipid clinic for evaluation after being discharged for acute stroke. It had paralyzed his whole left side and he was working on physical therapy. 19-year-old, his conventional workup was unrevealing, including all kinds of imaging studies and testing. Lipoprotein A was very elevated to more than 600 nanomole per liter. Normal is less than 75, so 9 times above the upper limit of normal. Case number two is an unfortunate, also 12-year-old male who presented to the lipid clinic at UCSF for evaluation after his twin brother had died of an acute MI. He had extensive cutaneous xanthomata in extensor surfaces of his arms, knees, elbows, and Achilles tendons since age 1. And some of them had been resected. This is not his particular picture, but I just wanted to show you what these look like. And his total cholesterol was higher than 1,000. Next slide, please. So I want to bring to your attention Lp(a). What we don't know, we want to get ahead of the game, right? This 19-year-old shows us that this can happen at a young age. So my first bullet point there is, can we do general neonatal Lp(a) screening to detect these families at risk? The answer is we don't know. Further studies are needed, but we do know that this is a highly atherogenic lipoprotein that is inherited. What's interesting is that in the first months of life, Lp(a) can increase up to 2-fold by age 1, from birth to age 1. But thereafter, after age 1 or 2, your levels don't change much. So theoretically, we could detect these very early on. Next slide. So what do the societies say about, screening for FH, which you probably guessed, familial hypercholesterolemia, the second case, elevated Lp(a), that first case that I showed you, is that this is American Heart Association 2018 guidelines. We should, or it's reasonable, as it says here, to screen in patients with early cardiovascular disease, familial history by age 2. Age 2, how many 2-year-olds have a lipid panel? Mine do, but I don't know how many. And then it's reasonable, if you don't have that history, between ages 9 and 10. And then you do it again at age 17 to 21, because after puberty, your ApoB levels will increase. Next slide. I want to just show you this bullet point. Every 10 milligrams per deciliter increments of non-HDL cholesterol is associated with an increase in atherosclerotic burden equivalent to 1 year of aging. So in our patient with FH there, he had 1,000, let's say normal cholesterol is 200, he had the arteries of an 80-year-old. So elevated circulating markers of vascular inflammation and endothelial dysfunction are present in children with FH, reflecting early atherogenesis. So next slide. How early can we detect this? We use routinely carotid IMTs to find disease in phenotypic FH. We don't genotype everybody. We also could use coronary calcium, like Skye was showing us. Coronary calcium can detect about 25% of cases between 11 and 23-year-olds super early in phenotypic heterozygous FH. The homozygous FHs tend to affect more the aorta. They get aortic calcium. In contrast, coronary calcium is barely detectable in adolescents and general population. Next slide. So here is something that I recently started working, our group started working with artificial intelligence, machine learning, collaborating with an individual from the Berkeley School who does machine learning, and we've gained some experience. I'm going to show you one of our studies. So why is this important? Because the use of is gaining momentum because it's available. We have this high computational power and outstanding prediction accuracy. We can do these very complicated and very effective strategies that are aimed at prediction. And the machine does it. Some things that our minds could never get our heads around, right? And there's been significant improvement in qualitative assessment of imaging. For example, CT calcium, echocardiogram. We're all trying to create algorithms to improve the reading of these studies and help the poor doctors that are getting, these waves of studies to read. These algorithms can also build these holistic frameworks, and we can use as many informative features as we want: imaging, biomarkers, genetics, social determinants, watches, your cell phone as it moves, to obtain credible insights and early detection. And that will result in saving lives once we know these things. Next slide. So machine learning, here's one example. This is what I've had experience with. We study cytokines as markers for protection or promotion of cardiovascular disease. We took very few, 104 patients, 39 with coronary disease, 65 controls, and analyzed 65 cytokines in their plasmas. Next slide. What we found, it was by using machine learning, the area under the curve gave us 95% accuracy to detect a plasma. We inputted 35 cytokines, and it gave us a cytokine profile for that plasma. And with that, the machine learning algorithm could detect who had coronary disease, who didn't. I was blown away by the prediction accuracy that these machines can learn or can give us. Next slide. So the precision medicine platform from the American Heart Association is there. I want to make you all aware of this. This is not something super fancy and unreachable. And it's, next slide, please. Oh, I don't have the video that I was going to show you. Oh, I do.
Precision medicine will drive the medical breakthroughs of the future. Scientific collaboration on a global scale. The analysis of massive data sets with state-of-the-art tools such as machine learning and cloud computing in a secure environment. These building blocks are the foundation of this future. The American Heart Association has prepared for this new world with its Precision Medicine Platform, the flagship solution developed by its Institute for Precision Cardiovascular Medicine. Our researchers are using the secure platform today to advance scientific insight through collaboration and by leveraging next-generation tools for data harmonization, analysis, and management. we're bringing together diverse data sets to identify the next landmark discovery. We are building an ecosystem of strategic alliances to test new approaches to research and to develop simple solutions for the increasing complexity of data compliance and regulatory requirements. We invite you to join us as we build the future of scientific research. Take part in the revolution of medical discovery. Together, we can unlock the secrets that will empower us to better predict, prevent, and treat heart disease and stroke worldwide, and enable all of us to live longer and healthier lives.
Thank you for that. And I just wanted you to know that this is a global initiative. It's available to everyone around the world. And the nice thing is that you have access to the data sets. And I just want to ask Dr. Labarthe how he sees the next generation of precision-directed, I would say, assessment and prevention, as you think about every child needs to be assessed and encouraged. And could we use these tools or others? What are your thoughts about that?
Well, very briefly, Evelyn, my reference earlier to the need in the cardiovascular endgame to be closely following the progress of advanced technologies is something that I think you have illustrated very well in this presentation. From the perspective of improving population cardiovascular health, I think what we would want to be looking for is applications of newer technology that can in perhaps unexpected ways, capture information about the health, behaviors, social circumstances, and so on of individuals that offer the greatest promise of living a healthy life in good cardiovascular health, and to try to incorporate that knowledge in our thinking and in our programs and policies. Our vision looking ahead by 30 years to 2050 certainly suggests there is a lot of room for change in ways that we may not yet be able to imagine. But the story you've told is, I think, a reinforcement of the idea that we need to be aware of these advances and the potential they may offer for our goal of reaching 100 and thereby reaching 0.
Thanks, Darwin. You know, I want to apologize. We've gone a little bit over, but we do have two other colleagues that had brief comments. And Darwin, can you stay with us for a couple more minutes? And
if I had a 1-minute break, I could stay with you indefinitely.
Well, why don't we go ahead and take a little break then, and then we'll have Nirali when you're back.
Great. I look forward to that.
Okay. What a magnificent array of ideas we've heard about. We knew, of course, it would have the potential of going long, but I'm just in awe of the talent that's present with us today and the potential for us to all build together. Now, I know Dr. Ivy had a question, which isn't necessarily needing to be to Dr. Labarthe. So Dr. Ivy, if you're there and you want to unmute yourself and express your question, you're welcome to do that.
Yeah, I mean, Dr. Labarthe is raising issues around the, fetal maternal environment, but we have huge disparities in that area too. And it may be that Oliver or one of the other people can speak more to that, but when you're essentially setting the stage with low birth weight or poorer birth outcomes for cardiovascular disease, we can only make progress at that 100% level that he's kind of talking about, we should all start at 100% if we really try to make progress in the area of Black infant health.
Yeah, I can comment on that. So it's going all the way back beyond the child to the mother, huh? In terms of the pregnant woman. I think that the important thing is for the pediatricians to address cardiovascular health from a preventive standpoint and do the screen. It was very compelling and good information. It was just printed about looking at screening at age 2 and newborns. I think that someone also put in the chat box about ACEs screening. So ACEs, as people know, adverse childhood events, those lead to poorer outcomes for cardiovascular disease. So looking at the whole child and being aggressive about preventive care beyond what we do as pediatricians, anticipatory guidance, and checking lead levels, UA and blood pressure, but surely the psychosocial element and a strict cardiovascular element of being very aggressive about screening for cholesterol, I think will go a long way in that direction.
So we have just 2 more comments. And Darwin, the next person is Nurali Vora, who you might remember. Nurali was the graduate of our most recent Tahoe class. And Nurali is a stroke neurologist. She's the co-chair of the Silicon Valley group, and that she also has an interest in international and global health. And she has done a lot of work in Africa on stroke prevention. So Nurali, it's good to see you.
Thank you for that intro. And hi, Darwin. Good to see you after a couple of years.
And you.
And thanks for that overview and a good reminder for us subspecialty stroke neurologists at a tertiary care center about how important primordial prevention really is. But thinking about that whole equation, and we've been talking about Life's Simple 7, I feel like my hope is that that would also reduce overall atrial fibrillation burden. But as a stroke neurologist, I have to emphasize the importance of looking at atrial fibrillation and ensuring that, as we've said before, common knowledge becomes more common, and we're holding people accountable for when they do develop atrial fibrillation, that they're on the right treatment. And we may even need to be more aggressive about early detection of atrial fibrillation as a mechanism to get towards 0 stroke, death, and disability, and how that might play a role into the overall primordial prevention and social determinants of health of having able, independent, working families together. And so I'll just make a few quick notes, right? We all know that atrial fibrillation accounts for probably 20% of strokes, more in the older population traditionally, but increasingly we're seeing AFib as a route for stroke in younger individuals. I think that we're all very clear that anticoagulation can help reduce the relative risk of stroke by 40% more than a simple aspirin, and that the risks of those medications are dramatically reducing as we come out with these new direct oral anticoagulants. The Avaros trial showed that there's nearly equivalent bleeding risk between aspirin and apixaban, for example. And so, and reflecting on everything we've talking about, and perhaps the checklist that we need to hold up for our patients as we go through Life Simple 7 is also at some point when we're flipping over into making sure that people are reaching their targets, that we consider as we go through precision medicine, what are the risk factors before someone has a stroke to really check for atrial fibrillation. And I think this is becoming increasingly easy with detection, right? We have prolonged cardiac monitoring increasingly available. That's easy to use and detects stroke, far more common than routine EKGs and Holter monitoring. So I think that stroke detection, atrial fibrillation detection is critical, and then ensuring that we implement the right treatment for those patients. So I just wanted to make that point about AFib, and a quick additional note that certainly ensuring access to acute stroke therapies is also critical, again, to maintaining the independence of a family unit and of a patient, and that we're having increasing opportunities in therapy that are extended beyond what was previously a critical narrow 4.5-hour window for TPA to over 24 hours that a patient can present for acute therapy with mechanical thrombectomy. And increasingly, we're pushing that boundary for even IV thrombolysis that's more readily accessible, and reminding all of us that perhaps part of this primordial prevention equation is keeping, we can't forget about those other individuals who then end up with disability, keeping them independent. Any thoughts on that, Darwin?
Well, first, good to see you again, Nirali. And sort of responding to a couple of the things you mentioned. I don't know if you have in mind, I don't know if you are calling attention to factors relevant to risk of atrial fibrillation that may not be reflected in the current Life Simple 7 defining cardiovascular health. So I would be grateful for your thoughts about that we could follow up perhaps after today. I would want to say that American Heart Association evaluated the Life Simple 7 metrics for their relevance to brain health and essentially endorsed the same Life Simple 7 as key indicators for long-term brain health. And in that connection, when in shorthand, I speak about CVD, I mean C cardiovascular and C cerebrovascular disease, cardiovascular health, cardiovascular and cerebrovascular health. So we are cognizant of the relevance of these factors to long-term development of stroke risk. But I'd be very interested to get further into this question about factors that are predictive of atrial fibrillation that should be addressed either alongside or perhaps as an evolution of Life Simple 7 as we see it today.
Great, thank you. And so the last question is from Bill Blommer, and Bill is also a very active person in Right Care. He's a statewide chairman, and Bill has been very active in the cardiology community. He is currently on the executive committee for California. He's had former roles as president, vice president, governor, and member of the board of governors. And Bill's also been a professor of clinical medicine at the University of California, Davis, where he's had a very long and distinguished career, both in service to the field of cardiology, but in training generations of cardiologists. So Bill, thanks for joining us.
Thank you very much, Bob.
I got disconnected.
I appreciate that. And I am on share screen. Can you see my screen?
Yeah.
All right. So one of the tasks Hattie had said, how do we get to zero? Is there an equation for it? And so we wanted to look at a little bit of that. I certainly want to thank Darwin and Janet, our prior speakers, and our panel for excellent discussion on this area. We had thrown around a couple of things related to equations, and the first, as you can see, is on the top, the Inner Heart Salem Youssef study, 52 countries, multiple ethnic groups. In red, if you can see there, are the risk factors that were associated with increased cardiovascular event rate. And as you can see in red is cholesterol, is smoking, is psychosocial aspects, diabetes, hypertension, and abdominal obesity. Those are all things that fit on top of or in the numerator of the equation and increase risk. Whereas the things on the denominator shown in green, fruits, vegetables, physical activity, moderate alcohol, actually all reduce risk at that time. So those are things that we can think of in an equation, but as you can see, they're very close to the simple 7 as far as doing it. And the way to get that risk or that equation to 0 is to emphasize or encourage the things in green and reduce the things that are risk factors in red. The second line shows you the risk calculation equation for the pooled cohort. And in simple terms, again, in red, age, cholesterol, low HDL, and systolic blood pressure are additional risk factors, even though we're looking at a log relationship for that. Some of the other risk factors that are there shown on the bottom as potential: CRP, microalbumin, cardiorespiratory fitness, calcium score, parotid thickness, LP little a, we've talked about. They're not yet in the formula as we acquire more data for that. So what do we do? For our group, we encourage for Right Care Initiative to follow the guidelines. So here are the ACC/AHA guidelines for prevention of disease, and they really have a lot of what we've talked about today in them, and they put it in perspective. For secondary prevention, statin therapy, as we've discussed, is recommended in a large group of individuals, and almost everyone on this group with or recommended for statin therapy, as well as lifestyle therapy in blue. And if we go to the next slide, let me end this. If we go to the next slide, this is the primary prevention guidelines that are outlined by ACC and AHA. And we've discussed a lot of these, and we can see for diabetes, clearly they would need statins as discussed. And we can see that for individuals at higher risk, higher than intermediate risk, they certainly would need it as well for that. We can see that some of the things we've discussed for unusual or non-traditional are seen on the left for risk enhancers, and they include things that we've discussed today, including LP little a and cholesterol levels and familial cholesterol as well for that. And for that intermediate group that we have, you can see at the bottom, coronary calcium goes in for selected individuals as well, that we can see for that. And we can see that lifestyle and statins are recommended as our primary prevention therapy. For hypertension, we can also see that for hypertension, that there are recommendations. We have new things, and we do follow the guidelines for Right Care Initiative recommendations, and we've emphasized those to our clinicians for that. Both lifestyle and treatment are seen in the blue and the red areas. And with appropriate blood pressure reduction, we can see that there will be lives saved, and it's estimated that better control of blood pressure through medication could reduce 40 million deaths a year and save 40 million lives. Coronary calcium, Joe did a great job of discussing that. And we can see for individuals with higher calcium, over 100 and 400 shown in the lower graphs, there is a dramatic improvement if they are placed on statins for that population. Now, Joe presented pilots. They had most of those individuals, the majority, 2/3, had zero calcium. So if you look at a young group, and certainly in teenagers, almost none of those individuals without familial hypercholesterolemia will have coronary calcium. So there's a very low risk group. And this shows in the bar graphs here, a trial we did, or a study we did with the Cardiovascular Health Study, where we looked at older individuals over 65 years of age. And what you can see on the top is men had a very low chance of having a zero coronary calcium, 6%, and women 11%. So as you get older, most of us do get coronary calcium. And therefore, scanning older people probably doesn't make sense. And therefore, we recommend coronary calcium for that intermediate group in selected individuals for that, where it seems to be the best differentiator for risk in the intermediate group. And that's often individuals who are 45 to 65 years of age. And obviously, what do we recommend for those individuals? The simple 7 shown here for the American Heart or for the ACC. You can see essentially the same as American Heart Association with blood pressure, physical activity, diabetes control, diet, and tobacco cessation and cholesterol control are recommended for those individuals. That was ACC. Here is the American Heart Association. Essentially the same graphics that we see here with eating, weight loss, exercise, smoking, blood pressure, cholesterol, and diabetes control recommended for that group. So what do we do or focus on for right care? Because we're dealing often with community health. Well, we've looked at interventional across California. We've developed a program where we've improved outcomes of all individuals having coronary interventions through an iterative process, looking at outcomes and evidence and feedback to the individual community. So what do we have for California? As you know, Right Care is focused on 4 communities: San Diego, LA, Sacramento, and Santa Clara, or the Bay Area. And if we look on this particular California map, and we look in the San Francisco Bay Area, we see a color that would suggest a relatively low rate of heart disease. In fact, looking at the state, Santa Clara, San Mateo, Marin, San Francisco have a rate of 70 roughly for age-adjusted annual death rate from heart disease. It's a little higher in San Diego and certainly in Sacramento and LA for that, but the Bay Area is the ideal place. Now, what we know is in the areas that we are focusing on for Right Care, we have good or fair performance or outcomes in heart disease, but look at the darker red areas in the state. These areas are throughout the state, the inland valleys and the northern rural areas. They have a mortality from heart disease that is 2 to 3 times higher than what we see in our communities. So if we're going to improve cardiovascular health and care in California, we need to continue working on our 4 sites, but we have some sites that have very high event rates, and we need to perhaps expand to those other areas, because unless we get those high risk areas under control, we'll have a hard time bringing cardiovascular health care under control in California. This is now the death rates for cerebrovascular disease. You can see again, the Bay Area is a great area. Santa Clara is doing an excellent job. So we need to focus on that, but also on the areas that are dark red there that again have a 2 or 3-fold increased risk in the dark areas for cerebrovascular death rates from stroke. And for diabetes, it's the same. The Bay Area, Santa Clara comes out ahead, and the other areas are less effective or have higher mortalities as we go down the line. And some areas, again, have 3 times the rate of death rate from diabetes in the state. So we certainly have a diversity across California. And for Right Care, where we focus on improving health in communities, we have a lot of communities there that need a lot of work to improve. Now, the next map I'm showing here is a map that also shows the Bay Area, Santa Clara, Marin, San Mateo, as being in darker blue there. And what does the darker blue represent? Remember, These are the areas that are doing very well in performance or outcomes for cardiovascular disease. What we see is these darker areas shown on the right are associated with a very high income. So this pattern that we see here is inversely to what we saw before and shows that the areas of highest income are the areas of best performance, meaning the lowest rate of death from heart disease or stroke in California. So there is an association of higher mortality with lower income that we see in the state of California. That's been seen as well, not in the US, but across the world. And here this again shows for the typical risk factors for cardiovascular disease that you can see low income in beige there is associated with a 3 times increase rate of death compared to high income groups, which are in the darker blue. And that's true for almost all of the risk factors associated with cardiovascular disease. We have another equation there, but suffice it to say, low income is a social economic aspect associated with high risk. And this is shown on this map here, or this graphic, where we can see on the left that the things that affect our risk factors are age, education, and income. And they have a dramatic effect on who, in fact, comes up short for diet, physical activity, obesity, alcohol, and smoking. So the things on the left feed the things in the center, which are the risk factors that then feed the things to the right, which are the clinical disease that we see, eventually leading to ischemic heart disease. So it's a complex equation that we have for that. The integral is shown on the bottom right, but we don't need to focus on the equation right now so much as the idea that social aspects do play a determinant for the disease pattern that we see in California.
I think we just lost Bill. I don't know how that happened, but I think he might have lost his internet connection. I just want to say, Bill, I can see your name, but I can't hear you. Dr. Kaplan had to hop off to teach a class. And I do want to say before we continue, just process check. I think all of this builds into a potential Delphi process. Obviously, too much complicated information to try to put into one equation today, but a huge amount of progress. And I would just, Bill, are you able to go to your next slide? I'm not sure we have you with us. It seems to have frozen for him. So Darwin, I would just love to hear your thoughts, if possible, on where you think we can go with this, given the immense amount of talent involved here.
Well, you all are experts. RWJ says you're the standard for how to conduct collaborative community planning. I think the suggestion of a Delphi process or some other focused sequence of conversations could be very helpful in bringing all of the interested parties who have things to contribute, including community representatives, into the discussion. Obviously, there are a limitless number of topics that could be discussed. One just relating to Bill's presentation just a moment ago, the prominence of education and income as factors influencing health. What do we do about that? I think Scott Flynn had already raised the question about social determinants. Do the adverse social influences have to be fixed before we can make major progress? Or are there ways we can make major progress working past or around them in order to move our actions closer to our goals. So I think there's opportunity for extending this discussion. You all have had the opportunity to bring together speakers from a number of other areas over your history of convening these meetings. There might well be others that you would think could be a part of that conversation. One thing I did not mention, interest of time, is the National Forum for Heart Disease and Stroke Prevention, which was established in 2006 as a way to mobilize and sustain effort behind the Public Health Action Plan for Heart Disease and Stroke Prevention that Bob referred to earlier. The National Forum has a culture of bringing together as a convener interested parties from very different perspectives, sometimes with baseline fundamental differences in perspective, point of view, opinion, in order to address some of these difficult questions. The Value and Access Initiative is one, for example, that has brought together pharmacy and major health systems and political and economic thinkers and so forth. So this may be a setting in which this kind of conversation could be continued alongside or on behalf or with the good company of Right Care.
So I want to say the thing that really inspired this day and this concept was seeing 2 articles published about the impact it had to bring together community, first in San Diego, then Sacramento, then Los Angeles, then the Bay Area, to drive those 3 targets and to see the very substantial and rapid reduction in acute myocardial infarctions. And then to think, well, we barely even scratched the surface of what can be done. And right about that time, learning about the power of precision tools to really understand earlier, in less, in uninvasive, inexpensive ways, groups that need interventions. And building on the military data there, I think we just have the opportunity to take this much farther. And granted, we are a very low resourced organization, and it's not for us to figure out how to take the learnings broader, but thank goodness for you, as you can help us think about how do we spread these really important concrete ideas like those raised by Dr. Duddle about, just proper use of the good old-fashioned generic metformin for pre-diabetics, and using something that the military created decades ago for understanding who is at risk beyond what the standard risk calculators say. Dr. Skye, can you unmute yourself and talk about that zero, your concept of getting to zero with that additional tool?
Oh, sure. But I really like the way that Dr. Labarthe have tried to define things in the opposite as to getting to 100%. But in any case, I think that the Air Force experience with pilots, almost 6 years that I spent on staff there, taught me that when we bring everything together, the environment, the exercise, education on nutrition, as well as screening, we can get to remarkable levels of preventing coronary artery disease. And so I look forward to continuing to make those efforts in our communities. And as many of you know, I grew up in a blue zone, and so I really like Dr. Labarthe bringing back the story of New Karelia, where you change the environment around somebody so they don't even realize they're making a choice. The easier, the healthier choice becomes the default. And I think that in my experience, when we have the opportunity to do that for our patients, it's just so much more effective than it is to try and do it the other way around, where we get patients to almost swim against the current.
In fact, we had Blue Zones come talk with us when Betsy Thompson was helping us to co-lead our last in-person summit. And we were all very excited about the idea of trying to create a new Blue Zone in what is currently a hotspot, which is the California capital. The Sacramento region is really problematic, not only because of the average risk factors, but also because of terrible air pollution there. So, but it doesn't really feel, so maybe now that we're getting the vaccine out, we might be able to go back down that path. But the idea of in-person convenings is to inspire communities around health is still pretty much off the table, I think.
Well, at the same time, Hattie, I would say that what you are doing in Right Care with these meetings is making full and very effective use of communication tools that we didn't really pay that much attention to pre-COVID, and now have learned to benefit from in very important ways. I mean, this sort of gathering to me is extremely helpful. A lot of discussion and opening the possibility of further pursuit of these ideas in the future.
I don't know whether we just lost Keith Emmons. Keith, I see you turned your camera off, and I was just going to say, can you unmute yourself? Keith has been not only our tech guru, but he's our heart failure guru. So Keith, please unmute yourself and say a little bit about your leadership in the heart failure area, and so that you and Dr. Labarthe get to know each other a little bit. Even though you're in Santa Barbara and he's in Marin, we have an opportunity to make a connection here.
Yes, thank you. I've enjoyed this session today. It is a little bit long, and I've had to go out and do my job for a little bit, but we have a heart failure section that also addresses heart failure and the different treatment modalities and the different ways of prevention. And speaking of prevention, what I wanted to talk with Dr. Labarthe about was something he mentioned that he was doing with your communities. I thought you said that communities in Chicago, you had chosen a couple, but you didn't give too much more details about that. And I thought what you were doing in those communities was addressing, from the preventive standpoint, your approach to disease starting at the early age. And I just wanted to learn a little bit more about those.
Well, thanks for the question, Keith. The brief reference to Chicago had to do with the very large network of healthcare practices that are part of our program on community health in the Department of Preventive Medicine. And the point was that we now have access to the data for 500,000 children, and linkages now just recently developed with their other family members, so we can compose the family units and track a number of things about their health. From my perspective, part of the importance of this is the ability to potentially to track, at least in some of these practices, the growth chart. You know, can we institute in practice collection of the data on all 7 of the metrics? In many of the data sets available to us, there is a lack of data on physical activity and on diet, which limits, as in that first trajectories model that I showed, to what we term a clinical trajectory that is based on BMI, blood pressure, cholesterol, and glucose, because data on diet, physical activity, and smoking are not available in compatible ways, if at all, in these several studies. So our hope is that we will be able both to collaborate with interested practices to employ and evaluate through careful implementation research the ability to incorporate this approach in practice. What's its acceptability, feasibility, cost, and so on, and do we gain as much from it as we believe we can? So that's the essence of the major work we're doing in Chicago at this point as part of our AHA-supported center.
I didn't realize your N was so large. You said 500,000 children.
Correct.
Yeah, that's quite large. And a follow-up question would be, in incorporating some of the other things that were said today about social determinants of health, nutrition, activity that you just mentioned, has anyone looked at, and probably a intervention arm is not part of this yet, and I think it should be or could be, to look at community participation, the Chamber of Commerce participation, to develop different sites so that nutrition can be addressed through bringing in grocery stores here in Los Angeles, the Los Angeles area. We've had a large grocery chain close a store when they were required to pay their workers a little bit more money. And where did they close them? They closed them in the stores in the most needy areas for fresh fruits and vegetables, et cetera. So I'm wondering if there has ever been a look at community partnerships to address some of these social determinants of health, especially nutrition and activity.
Well, again, thanks for the question, Keith. And you've certainly struck on a fundamental issue that we need to be able to address. I mentioned earlier the One Brave Idea solicitation from American Heart and our response that we needed a cardiovascular endgame. And it should begin with focus on communities where momentum is already demonstrable. We talked about the specific example of San Diego as a sort of a front runner, but we had proposed collaborations in San Diego, Austin, Texas, Chicago, and Atlanta to begin exploring just this question: who in the community, and it would include grocers and pharmacists and other essential sectors in the community, local transportation and so on, can be brought together to discuss how do we overcome the problems we have? Back to the question, can we deal with poverty and education? Not all at once. Can we work effectively in spite of those challenges, which is part of what I think I mentioned is the work of Herman Taylor in Atlanta. In different African-American communities, how is it that some appear to be in good health, others not? What are the enabling factors, the positive social assets, and so forth? So I think, well, just to finish the AHA story, the One Brave Idea, we learned after the review our idea was a little too brave for AHA at that time. But the interest and the commitment continues. We have gone back to the drawing boards to try to make more compelling in our proposals the case for doing just what you're talking about.
And that's what we were hoping to embark on in the hotspot of Sacramento. Right before the pandemic hit, we were talking about trying to engage all those community partners in a specialized project. So the only community where Right Care has had a chance to do anything beyond the clinical has been in San Diego. And that was for a brief grant that we were involved in that the National Heart, Lung, and Blood Institute funded. And that funding ended in 2012. It was a GO grant. And as you can see, it very quickly in the graphs behind me had a very big impact. But what has really come to my attention is that in under-resourced communities like Sacramento that have a more diverse and complex populations like Sacramento, the need is greater. So while we don't have a wonderful community infrastructure there currently built to address trying to convert a society that really is very troubled with drugs and so forth, you know, we've done a pretty good job in moving the numbers clinically through Dr. Baumer's leadership. But that community aspect, it takes a lot of resources, a lot of boots on the ground energy to pull that through. And Dr. Skye, who is currently muted, was bringing in his colleagues from the Blue Zones to help create such a project for Sacramento when we all shut down from the pandemic. Dr. Skye, do you want to just talk a little bit about your vision for Sacramento Hotspot?
Well, I think we're all waiting to find out how we can get back to quote unquote normal after the pandemic, and I think I'm encouraged that there are a lot of efforts ongoing with community health. I'm also lucky enough here on base to try and rebuild some of those things that we had in the 1960s in the Air Force with our early space program, and recreate the communities here on base. And we're currently working with our wing commander here at Travis to do these types of things and to create health around our members, rather than to tell our military members to just stay healthy all the while the communities aren't what we remember from decades ago.
And I also just want to raise the issue of, for those who have a clear genetic predisposition, I think our clinical systems are doing a really poor job at addressing those families. So those who have multi-generational early cardiovascular issues, as someone from such a family, I can say, going to very fine institutions from Harvard to Stanford to Palo Alto, George Washington, none of them knew what to do about my early cholesterol numbers. So that really needs to change. It's just such an obvious thing. And so, yes, we can talk about the big community stuff, but we also really need our clinical systems to have ready tools that enable them to address what I call the large numbers. So those where you would anticipate a problem, where you have a parent or a sibling, for instance, die, before the age of 55 of a cardiovascular event. What screening tools should we be using for them? I really don't think even the best internal medicine doctors know that. And for the children of these families, and we are many, they're going to be seen by internal medicine or primary care. They're not going to go to cardiology or neurology.
Well, let me piggyback on that, Hattie, and ask Darwin about, the cost of genetic testing is coming down. Hopefully it'll come down a lot faster. I don't see our Blue Shield person on any longer, but I was going to ask, do you envision, we also talked today about different testing that should be expanded at the pediatric level. Do you anticipate in the future, perhaps some of the genetic testing looking for cardiac diseases to be included in these tests? The ACOG, for example, has come out for prenatal testing of a lot of congenital diseases now. So do you anticipate that for the same thing after the child is born, to look at some of the things that may be happening and can be predicted?
Yeah, well, I would say that the indications for the kind of testing, precision testing and so forth that we've heard about this afternoon are best established by those who have carefully evaluated the cost and benefit of those tools. And while, as Hattie points out, with passion, these are of critical importance to those who are affected. They're really a separate question from the far broader concern about identifying children who are in ideal cardiovascular health, those who have declined in cardiovascular health to the point where interventions beyond promoting desirable factors may be needed. And so these are complementary approaches. And there's no question, going back to Jeffrey Rose and the high-risk approach, the high-risk approach can be very effective for those at high risk, but it has a limited impact on the health problem of the population as a whole. And so it's, I think, the balance between these, which is in need of attention by all of us who are thinking about these problems, by those who make policy decisions about how the assets we have are allocated to promoting good health versus rescue of those who have already gone far down the path of developing risk.
I have to say, we have really pressed the limit of this wonderful invitation that Bob Kaplan made to bring you to introduce his lovely Right Care family to you, Darwin, and you've been so generous with your time and talents. So I have to say, clearly our group is very interested in your thoughts and learning and working together. And I want to say thank you for being with us and for patiently listening to these multiple perspectives. And we hope that we will have the opportunity to work with you on some of the issues that have been raised today. So thank you. And thank you to our leadership that have stayed with us. Our next meeting is going to be on a group with very high risk, which is the population from South Asia. That will be on the last Tuesday of this month, normally held at Stanford, but again, held by Zoom, and it will be from 4 to 6 p.m. And it will be led by our wonderful Dr. Nurali Vora, who many of you met for the first time today, as she's normally only involved in our Bay Area group, and this is our statewide group today. So Darwin, I hope that you will become a regular with us and help to lead our thinking to the next level. And Keith, thank you. And Joe and Nathan Wong is here from UC Irvine. He hasn't had a chance to say hello, but for another time. So,
well,
nice to see you. Really enjoyed your talk, Darwin.
Thank you, Nathan. Good to see you.
Great to see you so active still. It's fantastic.
Oh, we haven't finished the job yet, Nathan.
I know. You got to get to zero.
Now.
It's fantastic to see all these efforts going on with you and the CDC and Million Hearts, and great to see Larry is running that program now too.
Right. Well, it's been a privilege. Thank you all for your comments and questions, and I look forward to continuing to be in touch.
thank you, Darwin Labarthe.
Thank you.
Thank you for sharing your wonderful passion with us. And
You're very generous, Hattie. It's been my privilege. Thank you.